Hello everyone, welcome to my channel Physiotherapy Online Lectures. Today we are going to study goniometry, one of the important topic in exercise therapy. Now we will know what is goniometry or goniometer. First of all, we have to know the goniometer. The goniometer is an instrument that measures the available range of a motion at a joint. Okay, so how we'll know uh, about the available range of a motion of the joint through the goniometer. Suppose the shoulder joint flexion is about 180 degree, but in case of frozen shoulder, the joint is restricted and the flexion and abduction range of motion will know the flexion and abduction range of motion through the goniometer. Okay, so what is goniometer? It is an instrument that measures the available range of motion at a particular joint. Okay, and what is goniometry? The art and science of measuring the joint ranges in each plane. Each plane means um, every plane occurs in the joint of the joint are called the goniometry. The art and science of measuring the joint ranges in each of the plane of the joint are called as the goniometry. The term goniometry is derived from the two Greek words. One is gonia, which is meaning angle, and metron, meaning measurement. So this is the definition of goniometry. So goniometry refers to measurement of angles, in particular measurement of angles created at human joint by bones of the body. Okay. Next, how will the goniometer determines two of the most important part is one of is the joint position, and next one is the total amount of motion available at a joint. Total amount of motion. Suppose in the shoulder flexion, the total motion is 0 to 180 degree. The available joint motion is either 0 to 180 or 0 to it is restricted to 120 degree. We will know from the goniometer. Okay. Now the goniometer is of different types. It will study it later on in this channel. Okay, later on the goniometer types. First we'll go about the one minute uses of goniometer. It determines the presence or absence of dysfunction. Number one. Number two is establishing diagnosis. It helps in establishing diagnosis of it. Number three is developing the treatment goal of the patient. Number four, evaluating progress or lack of progress towards the rehabilitative goals. Number five is modifying the treatment protocol. Next, motivating the subject. Number seven is research purpose, and number eight is fabricating the orthosis. Now, before we'll know the types of the goniometer, we'll know the basic concepts surrounding the goniometer. First one is the joint motion. What joint motion? Under joint motion, there are two, yeah, osteo and orthokinematic joint motion, and number two is axial plane. Number two is range of motion. Number three, factor affecting range of motion. Number five is four is end field, and number five is capturer pattern of range of motion. In this portion, the most important is the end field portion. End field. this one. In each and every year, one short note from this Enfield comes in the examination. Okay, we'll study it in the details. In joint motion, we'll study in the second year in details about the joint motion, ortho and orthokinetic joint motion. Now, here we'll study it in short form. Orthokinetic joint motion is a term used to refer as the movement at the joint surface like slide, spin and roll. So, suppose in shoulder joint there are two types of joint motion. One is orthokinematic joint motion and number two is osteokinematic joint motion. So osteokinematic joint motion is the movement of the shaft of the normal joint of motion. In shoulder joint, normal joint of range of motion is the shoulder flexion, shoulder extension, abduction, adduction, internal rotation, external rotation. So these types of movement are the movement of the shaft of the bone. So this is called as the osteokinematic joint motion. And next one is the orthokinematic joint motion, which occurs within the joint. Occurs within the joint. Is termed as the orthokinematic joint motion, just like which occurs at the joint surfaces, that like sliding, spinning, or rolling. Suppose in flexion, the joint slides and spin. Okay, the joint slides and spins. Here is the uh, head of the humerus slides downwards in case of shoulder flexion, and it spins backwards. So this is the orthokinematic joint of motion. In axis and planes, you all know the axis and planes, and axis in plane is a frontal plane, whereas the axis is the anterior posterior axis, and movement is the abduction adduction movement. In sagittal plane, the medial lateral axis, and movement is the flexion extension movement. In transverse plane, the axis is the vertical axis and movement is the rotational movement. Okay. Normal range of motion, shoulder. Normal range of motion, flexion is 0 to 180 degree, extension is 0 to 60 degree, abduction is 0 to 180 degree, medial rotation is 0 to 70 degree, lateral rotation 0 to 90 degree. Elbow flexion 0 to 150 degree, and extension will be 150 to 0 in case of elbow. Forearm pronation is 0 to 80 degree, supination 0 to 80 degree, wrist flexion is 0 to 80 degree, extension 0 to 70 degree, radial deviation 0 to 20 degree, ulnar deviation 0 to 30 degree. Thumb carpometacarpal joint, abduction is 0 to 70, flexion is 0 to 15, extension is 0 to 20 degree, opposition is tip of the thumb or base of the tip of the fifth digit. Okay, metacarpophalangeal joint, flexion is 0 to 50 degree and extension will be vice versa as 50 to 0 degree. Same wise interphalangeal joint, flexion is 0 to 80 degree and the extension will be vice versa 80 to 0 degree. In case of digits, second to fifth finger metacarpophalangeal joint, flexion 0 to 90 degree, hyperextension 0 to 45 degree. Proximal interphalangeal joint, flexion is 0 to 100 degree. Distal interphalangeal joint, flexion 0 to 90, hyperextension 0 to 10 degree. In case of hip joint, flexion is 0 to 120 degree, extension is 0 to 30 degree, abduction is 0 to 45, adduction is 0 to 30 degree, lateral rotation is 0 to 45, medial rotation is 0 to 45, knee joint flexion 0 to 135, and extension will be 135 to 0. Okay, ankle joint dorsiflexion 0 to 20, plantar flexion 0 to 50, inversion 0 to 35, eversion 0 to 15, toe first MTP or metatarsophalangeal joint, flexion is 0 to 45 degree, extension 0 to 70 degree, first interphalangeal joint flexion is 0 to 90 degree, flexion of second to fifth PIP or and BIP flexion is 0 to 35 and 0 to 60 degree. Same as cervical flexion is 0 to 45, chin touches the chest, extension will be 0 to 45, looking at the ceiling, lateral flexion 0 to 45, rotation 0 to 62, seen in the line with the shoulder. Okay, thoracic spine flexion is 0 to 50, rotation is 0 to 30, lumbar thoracic spine flexion is 0 to 80, extension is 0 to 25. The factors affecting joint range of motions are the soft tissue tightness. The soft tissues may be due to prolonged immobilization of the tightness, may be due to the prolonged immobilization of the joint, injury around the joint, any joint disease like osteoarthritis, rheumatoid arthritis, or ankylosing spondylitis and tibia arthritis. And number two of factors affecting joint range of motion are number two is the adhesion formation. In case of adhesion formation, which occurs due to reduces the joint range of motion of the joint, lack of mobility leads to reduction in the flexibility and circulation around the joint structure. Number three, prolonged immobilization leads to adhesion formation and formation of contraction of the soft tissue around the joint. Number four, there will be increasing of collagen fibers and reduction of elasticity property of the fibers of the connective and soft tissues of the joint. And number three will be the injuries. Factors affecting joint range of motion. Injury, recent injury, inflammatory conditions such like osteoarthritis, rheumatoid arthritis, ankylosing spondylitis. In these cases, the joint range of motion decreases. Okay. And muscle bulk. Increasing muscle bulk causes reduction of the active and passive range of motion. When there is increase in the muscle bulk, it decreases the active and passive range of motion, such as difference in elbow flexion between a common and bodybuilders. And sex is the female will having less hip extension and hyper hip flexion, but it is opposite in the male. Age, range of motion will be more in children. Comparatively, the range of motion decreases in case of adult. Nervous system spasticity of the muscle, which happens in human listen, leads to hypomobility, and flaccidity causes hypermobility. And last one is insufficiency. This insufficiency, what is insufficient? The amount of force or tension generated by a multi-joint muscle. Whereas what is multi-joint muscle? What is multi-joint muscle? Okay, the muscle that crosses two or more joints. It is called as the multi-joint muscle. Suppose muscle says biceps brachii, which crosses the shoulder joint as well as the elbow joint. So biceps brachii is one of the example of the multi-joint muscle. But the amount of force or tension generated by a multi-joint muscle diminishes as the muscle moves the joint simultaneously. Okay, the amount of force generated by a multi-joint muscle will be diminishes as the proximal. In case of biceps brachii, the proximal muscle will joint will be the shoulder joint. In case of shoulder joint, and distal will be the elbow joint. In case this the biceps brachii diminishes the muscles, moves the joint simultaneously. The force diminishes across the elbow joint. This is referred to as muscle insufficiency. It can be either passive insufficiency or active insufficiency. The muscle insufficiency is of two types: active insufficiency and passive insufficiency. What is active insufficiency? It is one of the more important question in short note. These two are important: active and passive insufficiency, or you can say muscle insufficiency. It is the question may come as the muscle active or passive insufficiency, or insufficiency of the muscle, either active insufficiency or passive insufficiency. So we'll know about the active insufficiency. The active insufficiency of a muscle that crosses two or more joint. We already know active research muscle that crosses two or more joint occurs when the muscle produces simultaneous movement at all the joints it crosses. Simultaneous movement all the joints it crosses and reaches such a shortened position that is no longer has the ability to develop effective tension. When a prime mover means agonistic, becomes shortened to the point that it can generate or maintain active tension, active insufficiency is then reached. The shortening of the rectus femoris limits the full hip flexion. The rectus femoris is muscle is the quadriceps muscle. Uh, the shortening of the rectus femoris when you are doing full hip flexion, when the knee is also extended, the rectus femoris limits the hip flexions. Same wise, maximal shoulder flexion cannot be achieved simultaneously with maximal elbow flexion. When your elbow, see, when your elbow is flexed due to shortening of the biceps brachial. What is this? When your elbow is extended, your maximum range of motion of the shoulder joint is performed 0 to 180 degree. But when your elbow is flexed and the shoulder joint, you are trying to do your shoulder flexion, the joint range of motion diminishes to 160 degree. So this is the active insufficiency. And the same wise the passive, same wise the maximal knee flexion and maximal plantar flexion are limited also due to the shortening of the gastrocnemius muscle. Full knee flexion and full hip extension cannot be achieved simultaneously due to the shortening of the hamstring. These all hamstring, gastrocnemius, biceps brachii, rectus femoris, these all are the what? Multi-joint muscle. Here you see the multi-joint muscle. These all are the multi-joint muscle. Now we will know the passive insufficiency. When the opposing muscle, in case of active insufficiency, there was agonistic, okay? Prime mover or agonistic. In case of passive insufficiency, is the antagonistic muscle. When the opposing muscle or antagonistic is stretched to a point where it can no longer lengthen and allow further movement, passive insufficiency is reached. Okay. The passive insufficiency occurs when a multi-joint muscle is lengthened to its fullest extent at both joints. Fullest extent at the both joints, but also preventing the full range of motion of each joint it crosses. The range of motion can be defined. So this is the passive insufficiency. Next one is the range of motion, and it has a range of motion is another chapter, and next we'll study about the procedure of goniometry. Okay, in case of procedure, testing position is important, alternating positioning is also important. Why alternating positioning? Suppose the patient, you are doing shoulder flexion of a patient in the supine lying position, but the patient is unable to supine, then you have to achieve the alternative positioning That's why a new alternative question knowledge is required for the goniometric measurement. Next one is the stabilization is also required. Joint structure and function, normal end fields, will study the end field later on, anatomical bony landmark and instrument alignment. Next one is the skill required for goniometry. Position and stabilize correctly, move a body part through appropriate range of motion, determine the end range of motion or end field, palpate the appropriate bony landmark, align the measurement instrument with the landmark, read the measuring instrument, record the measurement correctly. Next one is the positioning. Recommended testing position at the joint. Place the joint in a starting position of 0 degree. Permit a complete range of motion. Provide stabilization for the proximal joint segment. What is stabilization? The recommended position helps to stabilize the subject body and proximal joint segment. Hence, the motion can be isolated to the joint being examined, and also isolating the motion to one joint helps to ensure the true measurement. Okay, rather than combined motion that can occur as a series of joint, the stabilization can be achieved by positional stabilization or manual stabilization. Next one is the types of goniometer. The types of goniometer is the universal goniometer. We use this is the universal goniometer. In normal day-to-day physiotherapy, we use this type of goniometer. Next one is the gravity dependent goniometer, or it is also known as the inclinometer. The gravity dependent goniometer is also known as the inclinometer. Okay. Number 3 is electrogoniometer, and there are also 1 minute. Here 3 types of goniometer are important, and another types of goniometer are also there. We'll come see. Universal goniometer, these are the universal goniometer, these are the electrogoniometer. Types of goniometer: gravity goniometer or inclinometer, single or twin axis goniometer, bubble goniometer, digital goniometer, smartphone software goniometer, and arthrodial protractor. These are the types of goniometer in the total types of goniometer, and in normally we use the universal goniometer, which is used most commonly used to instrument to measure the joint range of motion, which is constructed of metal or plastic. We'll see the universal goniometer is made up of either plastic material or metal. We normally use the metal one. The goniometer has 3 parts. It is parts of goniometer. It is the most important question frequently asked in the examination. The parts of goniometer. It is 3 parts: a full semicircle with a center called as the fulcrum, the stationary arm, and the movable arm. Okay, these are the parts of goniometer. Here we will study. The most common equal use of joint position is the goniometer. Here, these are the universal goniometer. Yeah, here is the part of goniometer. Stationary arm, it is a structural part of the goniometer and cannot be moved independently of the body. So this is the goniometer. Suppose this is one of the goniometer. Okay, one of the goniometer. This is the stationary, a fixed term or stationary arm. the fixed arm or stationary arm. This is the movable arm, and this one is the fulcrum. So each one is the fulcrum. This one is the stationary arm, and this one is the movable arm. Okay. The stationary arm, it is a structural part of the goniometer and cannot be moved independently of the body. And the moving arm, it is attached to the fulcrum in the center of the body by screw-like device that permits arm to move freely. And the length of the arm varies to 1 to 16 inches according to the size of the joint. Okay. Here is the next one. Here is the next one, gravity dependent goniometer, which is also known as the inclinometer. They use effect of gravity on pointers and fluid level to measure the joint position and motion. Next one is the pendular fluidometer and fluid goniometer. The pendular goniometer consists of a weight pointer hanging from the center of the protractor. This one is the pendular goniometer. Okay. A fluid or bubble goniometer has a fluid-filled circular chamber containing an air bubble. Here, the fluid-filled circular chamber is a fluid-filled circular chamber containing air bubble within it. It has 360-degree scale. Okay, an electrogoniometer used primarily in research to obtain dynamic joint measurement. Most devices have two arms similar to those of universal goniometer. Two arms are movable arm and stationary arm. Now we'll know about details of practical goniometry. Here the questions comes from the suppose you have to measure the shoulder flexion. What will we do? Here is the example. Shoulder flexion. Measurement of shoulder flexion through goniometer. Here comes the fulcrum. The fulcrum will be positioned close to the acromion process. Okay. Here, suppose this is the fulcrum close to the acromion process in case of shoulder flexion. And the stable arm in the mid axillary line of the thorax. Here, mid axillary line of the thorax, and movable arm aligned with the lateral midline of the humerus. Lateral midline of the humerus. Here is the movable arm. Lateral midline of the humerus. And lateral epicondyle as the reference, which has the lateral epicondyle as the reference point. And the infield here is the, in case of shoulder, infield will be formed because of the tension of the post band of the coracohumeral ligament, the posterior joint capsule, teres minor, teres major, and infraspinatus muscle. So this is the procedure of measurement of the shoulder flexion. Okay. In case of shoulder extension, same way the fulcrum will be close to the acromion process. Here, fulcrum close to the acromion process. Stable arm same as the mid axillary line of the thorax, and the mobile arm aligned with the lateral midline of the humerus and lateral epicondyle as a reference point. Here also the infield will be formed. The tension in the anterior band of the coracohumeral ligament and anterior capsule. The tension in the anterior band of the coracohumeral ligament and the anterior capsule. Now abduction Same-wise, fulcrum is close to the anterior aspect of the acromial process. Stable arm is the midline of the anterior aspect of the sternum. Mobile arm aligned with the median midline of the humerus. An infield will be formed, and the tension in the midline and inferior bands of the glenohumeral ligament, inferior joint capsule, and the latissimus dorsali pectoralis major muscles. Medial rotation, the furcal will be at the oblique process. Okay, the stable arm will be at the parallel to the perpendicular to the floor. The mobile arm along with the ulna with oblique process and ulna stylet as the reference point. Ventral will be the posterior joint capsule and infraspinatus and it is minor muscle. As the next one is the lateral rotation. Same wise, fulcrum will at the oblique process. Here you can see fulcrum at the oblique process. This one, this position is used. This position is used for measuring the lateral and medial rotation. These two positions, and this position is used as the flexion and extension, and this is for abduction adduction. Okay, same as the parallel to the perpendicular of the fourth stable arm, mobile arm along with the ulna with oblique process and ulna stylet process as the reference point. The infield is also formed and tension is 3-band glenohumeral ligament. Here is the measurement. Same wise, in case of elbow, the fulcrum over the lateral epicondyle of the humerus, stable arm lateral midline of the humerus, in center of the acromial process as reference point, mobile arm lateral midline of the radius, radial head and radial styloid process as reference. Infield is soft in case of flexion, but in case of extension, the fulcrum over the same as the lateral epicondyle of the humerus, same as the flexion, stable and lateral midline of the humerus, and center of the acromial process as reference point, mobile arm lateral midline of the radius, here the lateral over the lateral fulcrum is over the fulcrum is over the, this point is the lateral epicondyle. Okay, stable arm lateral midline of the humerus. Here lateral midline of the humerus, this one is the stable arm lateral midline of the humerus, and the movable arm is also placed initially at the lateral midline of the humerus and ends up in the radial head, the end position, starting position and ending position. In details, we'll study this procedure of each and every joint in next chapter or next video. We'll study it in details. Okay, thank you.